Hello again, everyone, and welcome back to our Sarcoidosis of the Eye Patient Day. I'd now like to introduce our next session, which is visual impairment as a result of neurosarcoidosis. And our speaker is a very good friend of SarcoidosisUK, and we're so grateful to have Dr. Tarunya Arun here with us today. Now, Dr. Arun is consultant MS neurologist and the research lead for neurology at the University Hospitals of Coventry and Warwickshire. She has a special interest in neuroinflammatory disease, and she is the chair of the Neuroinflammatory Special Interest Group of the Association of British Neurologists. Her research interests include multiple sclerosis treatments and imaging and neurosarcoidosis, which is what she's here to talk to us about today. Dr. Arun, thank you so much for being here, and over to you when you're ready.
Thank you very much, Leo. It's an absolute pleasure to be here in your midst. So thank you for your invitation. I'll attempt to share my screen and hopefully that should work. Yeah,
we can see that. Perfect. It's working.
Okay, so as Leo sort of says, I think I'm interested in neuroinflammation in general, but neurosarcoidosis, and today, I think the task which has been given to me is essentially to talk to you about the neuro-ophthalmological findings of neurosarcoid, and then how we initially come up with the diagnosis of a neurosarcoidosis in the midst of people having general sarcoid symptoms. Equally, patients having sarcoidosis without a known diagnosis of sarcoidosis for the first time presenting with a neurological presentation of sarcoid, which can be in different locations, as we'll see in the next few slides. And then also the manifestations which are neurological but not unrelated to sarcoidosis, people essentially having symptoms related to that. So just as a small summary, I know that you've been hearing about sarcoidosis and it's sort of the initial presentations from Dr. Westcott already over the last 45 minutes or so. But just as a very quick summary, we know that sarcoid is an inflammatory condition. It does affect multiple organs, and there are not many organs in the body which are spared of these involvement with this inflammatory condition. We know that the problem really is that we have these abnormal masses or nodules which tend to form in different organs, and that those inflame the areas of tissue, either by way of those nodules or because of the way these cells from sarcoidosis infiltrate these organs. Patients can have different manifestations. And it's also possible that the granulomas actually alter the function, normal structure of an organ, and then obviously the function of an affected organ as well, in this particular case, as we're going to see in the case of the eye. Now, the hallmark of sarcoidosis, which pretty much underpins, as we've just been saying, are these granulomas. So what are granulomas? So granulomas are really those structural bodies or those entities which one has, which is full of macrophages, epithelioid cells, and giant cells. So these are all cells which we all normally have, but in a way overexpressed within these granulomas. We also have a number of different chemicals and tissue factors which these cells actually produce within these granulomas, responsible for a number of symptoms which we have, either visible or invisible in patients with sarcoidosis. Now, what about the epidemiology of sarcoidosis, which means to say that, what is it that we actually see in terms of on the ground, on the floor, the number of people with sarcoid? We know that the certain populations, particularly the African-American populations and populations belonging to sort of the African and the Caribbean race essentially have got a higher incidence, and that tends to be sometimes 3 times higher than when we look at the European or the American population when we age adjust them. We know from figures that although it is a rare disease, it's not as rare actually. So 1 in 10,000 people can have a manifestation of sarcoidosis in the UK. And the mortality rate, again, I think this is something which we sort of know as a known figure, but perhaps much higher in practice. So mortality from sarcoidosis can reach up to 7%. And then, of course, a higher incidence of other conditions which come with it, So people having autoimmune disorders, so it's not unusual for people to have other autoimmune conditions with sarcoidosis. And of course, there is also a higher risk of malignancy, particularly hematological cancers and skin cancers in patients with sarcoid. Now, what we sort of are going to speak about today is neurosarcoid. Now, neurosarcoid, when anyone sort of discusses neurosarcoid, I think the first word which is usually mentioned is rare. But actually, with many of us running these clinics sort of day to day, if you look hard enough, it's not as rare. So neurological involvement in sarcoidosis can occur in about 10% of patients with sarcoidosis. And in about 1% of patients, this can be the first time that patient actually presents with sarcoidosis is with neurological involvement. So it's very important to actually consider that. It's also important to remember and recognize that unlike some other organ involvement in sarcoidosis, pulmonary involvement sometimes in sarcoidosis does not actually need treatment. So people are monitored year on year. But CNS involvement, neurological involvement in sarcoidosis does have an increased risk of mortality and also significant morbidity. So a number of patients well treated with sarcoid continue to have a number of symptoms which can then go on for years after they've actually been what is deemed to be successfully treated. And that's not something which might be new to several of you listeners who actually suffer the condition. And actually, complete remission, if there is something like that within sarcoidosis, is only present in about 1/3 of patients. So about 1/3 of patients basically are asymptomatic when we continue to follow them up at 5 to 10 years. But again, that is sort of fairly rare phenomenon. Now, neurosarcoidosis, again, affects a number of different organs, so a number of different parts of the nervous system. So it essentially can affect the brain, it can affect the spinal cord, it can affect your peripheral nerves. And again, this, just as a repetition, so mortality is kind of, fairly significantly associated with it. It can cause people to have a different presentation. So they can be it can affect the head, the neck, and the limbs in so many ways that people can have weakness from it, numbness from it, difficulty in sort of vision, so which again we talk about in just 1 second. And then of course people can have a number of manifestations associated with that inflammation of not only the brain but also within the coverings of the brain and the inflammation on the blood vessels of the brain itself. And so neurosarcoidosis can also cause tissue destruction within the brain, so causing brain parenchymal disease and sometimes spinal cord pathology, also causing that tissue destruction. Now, what is the sort of, what is the scenario with optic neuritis or optic nerve involvement? So this is a little bit of work which we did as a part of my group. So in a few years ago, when we actually looked at what is the involvement of different parts of the body in patients with neurological involvement in patients with sarcoidosis. If you just take a group of patients, so we looked at about 80 patients with sarcoidosis, with neurological involvement. So these patients had biopsy-proven sarcoid. And actually in that group, we found that the number of people with ocular involvement, so optic neuritis, which was documented, obviously a lot of it can also go unrecognized, essentially reaches somewhere sort of, between 15 and 20% in this particular cohort. Again, eye involvement. So this is a frequency of what is a systemic sarcoidosis, so people essentially having neurosarcoid, but actually what other systems can be involved. Unsurprisingly, lung sort of involvement is very common. So most people in neurosarcoid have got a degree of lung involvement, or they've got a bit of lymph node involvement, which essentially leads to the diagnosis. But actually, if you see the ocular involvement in sarcoidosis, it's pretty much coming to sort of, that kind of range where it's not within the unrecognized sort of, lower sort of intensity or frequency symptom. It's actually quite a common symptom. And so, as I said, when I sort of opened the talk, was that neurological involvement in sarcoid can essentially be because one actually has those granulomatous inflammatory sort of lumps causing the process. Sometimes it can be because sarcoid is associated with other parts of the nervous system, not necessarily because you've got neurosarcoid, but because you've got systemic sarcoid. People get headaches, people get fatigue, and a number of other complications which go with having sarcoidosis as a condition. And then, of course, there could be complications of therapy or immunological alterations of sarcoidosis. So that's not something to be belittled. So a lot of us who look after these patients look at side effects of sarcoidosis almost sometimes in equal proportion to the actual illness itself. So very important to consider that, particularly infections and those other immunological consequences of having treatment. Now, clinical features of neurosarcoid. So I know that's not the sort of the crux of the talk today, but just to sort of introduce you to some of the ideas of where all people can have involvement. You can have a cranial neuropathy, which is what we're going to talk about. So anything which basically involves the nerves which supply your head and your neck area. So people basically having vision problems or problems with their hearing, or people having problems with sensations of their face or movements of their eye, or essentially having problems with facial movements, for example, or swallowing or speech issues. So those all come under the umbrella of what we call cranial neuropathy. That's the commonest presentation with sarcoidosis. And then, of course, you have meningeal involvement, so patients essentially having headaches. Sometimes the scans can actually look normal, and then we look a bit closer, and actually they've got what we call meningitis without infection, or what we call aseptic meningitis. And then that meningeal involvement almost being the culprit for a number of other problems which we usually have, such as blockages in the brain causing conditions such as hydrocephalus, or problems of the nerves causing various nerve palsies. And then we have the parenchymal involvement, which we talked about. Parenchyma is the tissue of the brain or the spinal cord itself, and that can be involved. So people can present with seizures, for example. They can present with something which looks very much like a stroke. People can have weakness of their arms and legs, or all those sort of almost in unison. And then this is, of course, a very under-recognized part of sarcoidosis is the peripheral nerve involvement. So people actually having nerve involvement of the small nerves of the hands and the feet, and then obviously the muscle involvement as well. And that percentage of people with that involvement is not trivial, and sometimes can be up to 10% of patients. And then, of course, again, a very relatively rare manifestations of neurosarcoid, but not something we don't see. Perhaps we see a few cases a year of people actually having cerebrovascular disease. So someone who's thought to have a stroke, but actually the stroke is because someone has sarcoid involvement, either the granuloma pressing on a major blood vessel or actually causing vasculitis, causing people to have a stroke-like presentation. So cranial neuropathy, which is sort of, as I said, it's the most common neurological deficit in sarcoidosis. It causes a number of nerves to kind of have paralysis or weakness. So people can have facial nerve involvement. So that can be just on one side or both sides or bilateral. And that's usually the commonest cranial nerve to be involved in sarcoidosis. And then, of course, you have the eye not far behind, which can be just involving the optic nerve or the optic neuritis. It can also involve the nerves which affect the mobility of the eye or the motility of the eye, essentially having dysfunction of those nerves. And that can be seen in about a third. And among people who present with optic neuritis, about 60% of these patients actually have bilateral involvement. So optic nerve, which is involved in both eyes, which can either be recognized sort of, because people present with both eyes, or sometimes it can be what we call subclinical, or one eye involved and the other eye, you can only pick it up either on a scan or on testing. And then the vestibular or cochlear nerves, the one which supplies our hearing and our balance. So that, again, people presenting with hearing loss, which only initially is reversible. So if you sort of have a significant hearing loss and balance difficulties, and it is because of neurosarcoid, unless you capture this early and treat, sometimes can be very difficult to actually get complete recovery, and some people are very disabled by this. And then, of course, a number of other relatively infrequent, which is anosmia or loss of smell, and then pharyngeal or what we call vocal cord involvement, and sometimes can result in people actually having difficulty with their sort of speech, and sometimes actually with their breathing as well. Now, coming to sarcoidosis of the eye. Now, sarcoidosis of the eye, of course, is sort of, I'd like to look at it as three different segments. So you've already looked at what, to some extent being covered, and you'll hear more today in the course of the ocular inflammation from sort of, bigger experts than myself in that particular aspect. However, I think what I really want to touch upon today is the optic nerve involvement, and also the involvement of the nerves which supply the muscles which move your eyes, or what we call the extraocular muscles. So optic neuropathy or optic nerve involvement, that can be either the nerve itself or the nerve as it links up into the brain, can be involved depending on where you look at it in literature. And in clinical practice, we probably say about 2 to 5% of people basically have involvement of what we call the optic nerve pathways. So this can present in a number of ways. So people can either have an acute presentation, so someone who's really well and then suddenly wakes up with a very painful eye from which they can't really see. That is a presentation. This can be painful, or sometimes can be painless, loss of vision, painful more than painless. And then of course people can also have gradually chipping into the vision. So over a period of either a few weeks or sometimes a few months, people can actually have loss of vision, and vision just chips in. And then if you get weakness of the eye muscles, because the nerves which supply the eye itself can get involved, and that can sort of cause weakness of the eye, so causing squints, for example, and then other sort of neuropathies associated with that, such as abnormalities of your pupil and vision. Now, first we'll touch upon sarcoid-related optic neuropathy. So optic neuropathy is essentially So optic neuropathy essentially occurs when the nerves which basically supply the eye, which can be sort of the nerves which lead up from the eye to the brain, they become damaged in some way. So this might be because there is blocked blood flow from it, as people having a stroke of the eye. So people can have inflammation, or people can have swelling of the eye behind it. And there can be a number of other conditions which we all come across in day-to-day practice, as someone's had trauma to the eye and lost vision, for example. So all of these can cause an optic neuropathy, or a very unhappy nerve for whatever reason, where that signal transmission from the eye to the brain is interrupted. Now, optic neuritis is the most commonly diagnosed form of optic neuropathy. Optic neuritis, so the causes of optic neuropathy, as we sort of said, are numerous. So some of it has already been touched upon by some of my colleagues. So GCA was hearing that as we came in, which is giant cell arteritis. Drugs and chemicals, they can also cause a similar sort of issue. And then, of course, you've basically got, if you have any high pressure circuit within the brain, which is basically, for whatever reason, pressure in the brain goes up, the eye is a very good reflection of that kind of a setting, and that can also cause your optic nerves not to function as well. Now, optic neuritis, as I just said, is an inflammation of the optic nerve. So it usually involves the coverings of the optic nerve, which is the myelin, that can get damaged, and people get what we call a demyelination, so essentially stripping off the insulation covering of the nerve itself. And that usually results in typically blurred vision or dark vision. So someone who sort of has otherwise normal vision basically has a problem during the course of an optic neuritis. Now, there are a number of reasons why people could have optic neuritis. I think the reason why I want to just stress on this and say this is very important is essentially, I think sarcoidosis is very much in reckoning when we come to a diagnosis of an optic neuritis, but very often it must be a diagnosis of exclusion. So one needs to make sure that people don't have another condition causing optic neuritis. So obviously involves ruling out a number of different things. So I'm not going to go through this whole list, but just to sort of say that obviously with people presenting with optic neuritis, things such as multiple sclerosis or MS, which is usually the commoner presentation rather than people having a granulomatous process. So things which come into the sort of the inflammatory category need to be considered equally. Again, a very common presentation of optic neuritis, perhaps the commonest, is basically people having a viral infection, then losing vision for a few weeks, which usually then recovers almost completely. And then, of course, the rarer causes, such as people having TB, people having syphilis, or people having other forms of other infectious diseases, can also cause loss in vision. And then very rarely we see them as a cause of other conditions. So particularly in the last couple of years, post-vaccination, for example, or other things, but usually with fairly good recovery. And then, of course, inflammation of the eye going into the rarer conditions such as sarcoidosis, vasculitis. People are also having it as a result of other kinds of inflammatory conditions. So the damage to the optic nerve, again, to sort of reiterate, can be multifactorial. Now, what are the symptoms of people having optic nerve involvement, or optic neuritis? So the commonest, which doesn't come as a surprise, is actually people lose vision. So this can be just blurred vision or dimming vision. So the commonest terminology which is used by patients in clinic is that they feel like the brightness in their vision has been turned down. So they sort of feel that things all look very dull, looking through a frosted glass, feel sort of, as though the whole environment looks as though it's in poor contrast. You can't see lights as well. And this can happen, as I say, overnight. It can happen over a few days or can happen over a few weeks. Most people with optic neuritis, not all, but most people with optic neuritis will have eye pain or discomfort that can vary. So, and that can also sort of sometimes carry on once that person has had an episode of optic neuritis because of the involvement in some other nerves which happen in that area. So people complaining of this deep, boring pain behind the eye, which usually the pain tends to go away after a few days, even much before sometimes the actual vision starts to improve. And then people describing that washed out color vision. So everything looks washed out, traffic signal lights, people, their clothes, everything looks very washed out. And then of course there are other things which come with it. For example, seeing flashing lights or sparkles, or, if you're looking at things, people actually having those shifting squares. And then once that episode of optic neuritis is passed, people actually having optic neuritis, which is sometimes subclinical, i.e. you've not come to the doctor saying you've got an eye problem, but actually it's been picked up. Sometimes you can have worsening of the vision, for example, when people have a hot bath or the weather has actually become very hot, or you have an illness, for example. So all these things can result in the conduction in the optic nerve being impaired. And that can result in problems having episodically people actually having problems with their vision. Now, other symptoms, it's always, of course, very important to concentrate on the symptom which people present with, which is obviously in this particular case, the optic nerve, but very important to think about other things laterally. So very often, if one part of the nervous system gets inflamed, it's not very uncommon for other bits of the nervous system to also go into difficulty, or actually people to have flare-up of their sarcoidosis everywhere else. So very important to look at those clues, for example, headaches, which have been going on for a few weeks or months, for example, which in a person who's normally not a very headachy person, or people actually having problems with their gait, people having other issues, for example, their hearing going off a bit, or double vision. And people having other subtle signs, for example, involvement of the pituitary gland, for example, increased thirst, or people having increased need to go to the toilet because they're passing large amounts of urine, or other signs, for example, people having fatigue or sexual dysfunction. So all these can be problems which can be clues in a patient with optic neuritis that they may also have underlying neurosarcoidosis presentation. Now, people can have motility disorders of the eye, motility, i.e. the ability of the eye to move. So this person can see very clearly. So people with optic neuritis usually have no problems moving their eye, unless they have other nerves which are involved as well. So it is purely a nerve which dictates your vision. Whereas there are other cranial nerves which can be involved, where people can see perfectly well. They see double, sometimes very blurred because both the eyes can be involved. But here the eye's mobility is not very good. So either you have double vision or you can actually have blurred vision, and that can be involving one eye or both the eyes. So sometimes very important to look at as well. Now, in anyone who comes with a set of symptoms such as this, it's important, of course, to investigate. And investigation, the top on the list of tests is history. So, I think, very often, if there is enough time spent in taking a history, you pretty much come to a conclusion as to what the diagnosis might be. We still need to do tests, but history is so important, especially if you're going to rule out other mimics. MS, for example, presents with optic neuritis, but very often when you take a history, it becomes very apparent that this is not MS, this is neurosarcoid. Equally very important to take history for recent viral infections and recent vaccinations. Is there being also, are there other symptoms of neurosarcoid, which, if people are busy and they're leading an active life with friends and with family and generally with work, what you essentially miss is sometimes those subtle symptoms which you might have, and you might have had for a number of months. So from a doctor's perspective, taking that history becomes very important then. Then ophthalmological examination, again, I'm sure my colleagues will cover this in further depth and to a large extent, but just to sort of underpin the importance of the eye examination here. Sometimes it can be normal, but equally, it's very important in context of neurosarcoid. All neurosarcoidosis patients, I think, should have an ophthalmological examination for silent disease. And then, of course, imaging, very important scans. Again, you'll all be perhaps aware in some shape or form of the MRI or magnetic resonance imaging, PET scan, which then gives you an idea as to what other organ can be involved, sometimes, as I say, subclinically or without symptoms. And sometimes when you want to clinch a diagnosis and you can't obviously biopsy the optic nerve and you can't biopsy the brain, you need tissue from somewhere else, and PET scans are a very useful area to actually look at that. And then, again, no surprise at all, as I said, sort of 70–80% of patients have lung involvement, so a high resolution CT scan of the chest. Then ocular tomography, which is basically a test where we actually look at how thick the retinal nerve fibers are, particularly in people with silent disease. So, sometimes it can be used as a surrogate marker for actually monitoring disease. So people have recovered from their optic neuritis, but then actually what's happening underneath it, is their treatment actually working well, or are they actually losing optic nerve fibers even after the best treatment we've given them? Very important to see. And sometimes we use a test called a VEP, which is called a visually evoked potential, in order to suss out whether the person has actually had optic neuritis. So sometimes optic neuritis can be a mimic. So people can complain of just painful eye and then a headache or unilateral headache. But if there is a suspicion that this is not very clearly optic neuritis, which happens perhaps in about 1 or 2 in 10 patients, where you're not sure whether people have had optic neuritis, but the clinical suspicion is very strong, then a visually evoked potential might help, because it actually measures the conduction along the optic nerve in the eye, and that can be impaired in people whose optic nerves have been involved either now or historically. Blood tests, number of different blood tests, and of course CSF analysis. And sometimes we clinch a diagnosis just by looking at the CSF. So even sometimes the MRI scan is completely normal, CSF can be abnormal, and that's very important to recognize as well. So ophthalmology review, again, I'm just going to do a very brief touch on this, which is essentially just to say that people can have bleeds of their retina, or the sort of swelling of their optic nerve. So obviously, you will see that your neurologist or your ophthalmologist or your sort of some other physicians who look after you for sarcoidosis may actually take a ophthalmoscope and look behind the eye. And if you complain of a headache or a bit of visual blurring, that's essentially to see whether people have got a swelling of the optic nerve themselves. And then, of course, as we said, MRI. So very often we give something called a contrast with an MRI, and people can tolerate it. And this usually tells us whether that nerve is acutely inflamed or whether it's inflamed presently. Sometimes we essentially, we find that it does not light up when we give this contrast in an MRI scan, but or in the opposite eye. And of course, as I just said, the figure on the the right-hand side shows a patient with PET scan with sort of numerous lymph nodes, which all look what we call avid or sort of very sort of prominent on the PET scan, or very bright. And this then helps us to understand, depending on what pattern it's the lymph nodes are essentially involved, as to whether this person is sarcoid. And sometimes it helps us again to find out involvement of other organs, such as the liver, which may not be picked up, for example, on a routine scan, such as a CT scan. So this is just a picture of the OCT, which is just taking sections around sort of the optic, around the through the retina, and essentially looking at the thickness of it. So patients essentially with sarcoidosis sometimes can have, as I say, silent thinning of the retinal nerve fiber layer, and sometimes we use that as a very good surrogate marker in people who we think have got suboptimal response to treatment. Now, one of the reasons for doing the tests, obviously, is to make sure that person has sarcoidosis. And then, of course, we've also got some diagnostic criteria for neurosarcoid, which essentially divides people into different groups of sarcoidosis. So, for example, people with sort of very highly probable sarcoid. So these are people with definite neurosarcoid. We've taken a tissue from the brain or the optic nerve and diagnosed them. Some people have what we call probable sarcoid, where, you know, this is the usual commonest category where, because the nervous system is incredibly difficult to biopsy, so not everybody has got a brain biopsy or a spinal cord biopsy, because obviously they're associated with their own risks and mortality and morbidity. So there's a second category, which is a probable category. So this is something which you might all recognize, where you've had a lymph node biopsy through the sort of bronchoscopy, or you've had a skin lesion which has been biopsied, or you've essentially had other sort of areas which have been biopsied, and people have diagnosed sarcoid, and then people then have neurological involvement, and we call them probable. And sometimes we don't have pathological confirmation in patients, but we get other clues. For example, the CSF might be abnormal, the MRI looks very typical, the history looks very typical. So all that put together, I think sort of in an experienced sort of way, one can actually make sure that you don't miss a diagnosis with sarcoid. And of course, again, sort of not within the realms of this talk, but again, to recognize something called para-neurosarcoid, which is essentially the small fiber involvement within sarcoidosis. Now, assessment of treatment decisions. Now, again, what I'd really reiterate with this is that it is not black and white. Certainly, it is a partnership between the patient and the doctor. So sometimes it's very obvious that people need treatment, and we have that discussion. Sometimes if you have minimal symptoms, people have got a low risk of danger. For example, if you've got sort of a single nerve which is involved, for example, if you just have people presenting with facial palsy or a single episode of optic neuritis, and there isn't sort of, you know, other involvement, one might have conversations with the patient as to whether we just observe the patient, or we might go in the observation favored category, or sometimes you think that the person has got severe vision loss. So people presenting with optic neuritis haven't recovered function. You desperately have to save the other eye, or you make sure that the other parts of the body are not going to be involved, including not only the nervous system, but elsewhere. And then treatment would be favored, because there would be a very low likelihood of this person recovering completely without treatment. Now, I know that, again, there's going to be a conversations about treatment within people with sarcoid, but also to just touch on the treatment of neurosarcoid. So this is usually a stepwise fashion. So because of the complications of some of the treatments which lie on this side of the graph, where we sort of normally treat people, is usually at this level when people start. This is something which may be familiar to a lot of you who have sarcoid, is people are given prednisolone or methylprednisolone, which is the drip treatment or the oral tablets which you might have for 5 days, and then subsequently moving on. Very often, there's a lot of people, so a lot of us who treat people with neurosarcoid will then opt to give treatments concurrently or together in order to reduce the side effects of the steroids, or to make sure that people are getting their optimum benefit, where we would actually mix treatments, which will essentially be people being on steroids and people being on one of what we call the second level treatments. So this could be sort of a variety of different agents, which sort of can be methotrexate or azathioprine most commonly, essentially also very much dependent on where the disease is, and also dependent on where in the course of your life you are. For example, if you're an older patient or a younger patient, are you in the childbearing age group, when we would sort of, choose drugs such as azathioprine over methotrexate. And equally, Also depending on the most importantly, depending on response to treatment. Now, if people do not respond to either of these two levels of treatment, then we move on to the next level, which is obviously giving people something stronger. We know that people who've got sarcoidosis have got these granulomas, which have as I said, they produce a lot of what we call chemokines or cytokines, and one of the chemicals or produced is obviously the tumor necrosis factor alpha, and hence when you give something to stop it or inhibit it, one feels that the disease actually gets very much better controlled in a cohort of patients. And then we move on to treatments with infliximab or adalimumab, which you may again recognize. And in some patients, of course, treating them with rituximab or cyclophosphamide. So moving through the steps of treatment is important, but equally, I'd like to reiterate that moving through those steps sometimes has to be done in a timely fashion and needs to be done with fairly good level of monitoring, because sometimes it may be too late by the time one decides to move across treatment. So very important to hit hard, hit promptly and early as well. Now, I'd just like to finish off by just showing a case study of one of my patients. So this is a 32-year-old lady, really prime of her life, really. She's kind of working full-time and having two young children, so busy mom, busy working. And then of course, then she presents with a facial palsy. So she had one side involved first, and then she had a subsequent side involved again. And then she had other aspects, such as she had weakness of her legs, and she developed numbness first, and then some urinary difficulties, and that had been going on for a few weeks. And then within a week, she developed blurred vision in both her eyes, and this was particularly evident when she started to read. So she came in and then she got seen by ophthalmology. So they very quickly realized that she's just not got an eye problem, so she actually needs to come and see a neurologist. So she came to see me. So she at the time she presented, she was already into 2 weeks of symptoms with a number of other other neurological, very subtle neurological symptoms. And that's an MRI which we did when she presented. And what you can see on that MRI is what we call high signal within the optic nerve. And then the ophthalmologist also, as I said, did further examinations on her, and she's basically got a granuloma sitting right on her optic nerve head. So that's a granuloma, and it's sitting within the optic nerve head. So it's not a very common presentation, but equally not unusual if you're looking for it. So she then had a number of tests. So she had a CSF analysis. So she had high protein. So obviously at that point, the initial ophthalmological examination was it's a quick one. So this was the picture I showed you was on a subsequent scan, which essentially picked up that granuloma, but before which she had a number of tests. So she had CSF analysis, which showed increased cells. She had high protein. She also had a PET scan, which showed an increased uptake in the mediastinum. So the previous PET scan, which I showed you, was this lady's. And then of course, she had a biopsy because a PET scan showed she had lymph nodes in her mediastinum. She had a transbronchial lung biopsy, a bronchial biopsy of the lymph node, and she had a granuloma. She was treated initially with steroids and azathioprine because she was thinking about family, etc. And then she made quite a near complete recovery of her visual symptoms, really. But neurological symptoms also improved to some extent, but not completely gone. So 6 months later, she relapsed again. She had optic neuritis of the left eye, headaches, and she developed diplopia. And at this point, we scanned her, and what we essentially found that she also had involvement of this particular area, which is the brainstem, where you see this fluffy white area around her brainstem, and a little bit going into her brain parenchyma also. So we escalated her to infliximab very promptly, and then she basically was stable. And the scans changes have resolved, but unfortunately, she did actually lose almost completely vision in one eye because of that second attack she had, but actually has got preserved vision in the other opposite eye, and in fact doing very well neurologically. But sometimes the outcome may be very different. So, and very often it's I think it's also about looking at just not the eye, but sometimes outside the eye as well. I think that was all I was going to say. Yes, that's right. So that's all I was going to say actually with my talk, but obviously happy to take questions. Thank you.
Thank you so much, Dr. Arun. That was another Fascinating talk, and I think it's so important that we're also talking about neurosarcoidosis today. We have had some questions sent in, if you're happy to answer a few.
Of course.
Thank you. So somebody has written in and said, when my neurosarcoidosis flares, I need to sleep a lot. My sight is blurred if I'm disturbed from sleeping too soon. And this only resolves when they take more rest. Do you think this would be a neuro problem or a muscle problem?
Sure. Okay, so that's actually a very good question. And I think a lot of people would recognize this, not only people who have neuroinflammation because of sarcoid, but actually neuroinflammation because of other conditions. For example, my MS patients in relapse would say that exactly the same, and same would be for other neurological inflammatory conditions where people sort of flare up. So if you remember sort of in the beginning of this talk, and also you might have sort of recognized this yourself, is that when you have a flare up of your sarcoidosis, there is a release of a lot of different chemicals, which people sort of, there is a flare up. So people sometimes have a lot of cytokines basically being released, a lot of things which are invisible. So things which we can measure, a lot of things which we cannot measure. So having incredibly disabling fatigue sometimes can be a relapse. So people can actually have very, very severe fatigue. And there's usually a very, very punctuated period when people actually have, I was completely well and working and bang, and being hit by this massive brick wall, having relapse symptoms of fatigue. And that's not uncommon. And people will sleep for a number of hours during that period of time. Now, and also it's very recognizable that rest improves. So for example, if someone has a relapse because of neurosarcoid and attended sort of an appointment, we would usually give them we would usually tell them to take time off work or to rest. And that's precisely that. So any recovery from relapse happens better when you rest. And actually that's exactly what I think you're sort of, alluding to there in terms of thing. So although it may not be a sign of your neurosarcoid sort of actively flaring up within the brain, if you have general flare up of your sarcoid, the way, the brain is usually a reflection of the rest of your body, and the way the brain actually reacts back to saying, I've had enough and I need some rest. Or it might sort of, be a response to the massive chemical overload this person is actually having. And people feel hugely better when their treatment's altered or when they've gone through that period of rest. I hope that answers that. Yeah.
Absolutely. Thank you very much. Somebody else has written, I would like to ask about issues with the optic nerve and the pathway back into the brain. What tests are needed to pick this up? Would it be picked up by an eye hospital, or does some form of brain scan need to be done?
Yeah, so I'll answer that question, but also to say that sort of MRI scans and sometimes even clinical examination does not foolproof pick up 100% of optic nerve involvement. So, sometimes depending on where you look, and sometimes our own sort of figures would essentially say that about 10% or 20% of people have got normal MRI scans. So that's very important to recognize. So if someone comes with an optic nerve problem along the route of the optic nerve pathway, we would do we would go through the scheme of things which we've just talked about, where we would take a history, then they would have an ophthalmological examination. So sometimes it's just not the optic nerve which is flaring up in sarcoid, but actually everything in front of the optic nerve. So very often the ophthalmologist would be able to pick up other changes, as Dr. Wesker was sort of previously talking about, and as you'll hear, which essentially tells you. And then the MRI, in about sort of 60–70% of patients, the MRI is abnormal, things which I've essentially shown. We've also got a significant minority who have a normal MRI scan, so things which are completely normal. We, as I said, we would also do other tests to find out whether people have had previous optic neuritis, for example, such as the visually evoked potential, or sometimes the OCT examination, as I sort of alluded to. So yeah, so there are a number of things we can do to detect whether people have got optic neuritis, but bearing in mind that some of these standard tests sometimes can be negative.
Great, thank you very much, Dr. Arun. Just a couple more that have come in live as well. Somebody's asked, should optic neuritis be treated the same as neurosarcoidosis? Yeah,
again, very good question. Now, optic nerve is part of the brain, so we would essentially sort of treat optic neuro. If someone has optic neuritis, I think they've got neurosarcoidosis. So if anyone sort of has optic neuritis, you've got to think about it seriously. Now, in the form of neuro, if you think about anything seriously, but in terms of neurological involvement. sometimes, again, there are single nerve involvements, like somebody has just a facial weakness, or people essentially just presenting with, say, a numb face or a single episode of optic neuritis. You can just resolve completely with steroids, and there is a cohort of patients who don't need any treatment at all after a year. So that is kind of what we call a mononeuritis. So that's a presentation, but obviously need to be watched very carefully year on year. However, there is obviously a group of people with optic neuritis which can be very severe, and people don't recover as well. So if you've got a case of optic neuritis which doesn't recover after 6 to 8 weeks, then it's important to consider sarcoidosis within that group of people and not just be a viral optic neuritis.
Thank you very much. One last question that's also come in live. Somebody's asked, is it possible that neurosarcoidosis can resolve spontaneously?
Yeah, so again, I'm sure we'd be aware that sarcoidosis is no cure. So so that's very important. So when you use the word resolve, I'm presuming that you're sort of saying, will you recover spontaneously from a sarcoid episode? The answer to that is yes. So a third of the patients recover spontaneously, don't need any treatment. So, we've watched them very closely in clinic. People with sarcoid, even if they present with a single episode, are never discharged from clinic, but they don't need treatment because sometimes you weigh up the risks of giving people treatment versus actually watching them closely. Very important, because sometimes giving people treatment for a single episode can be quite disabling themselves in a high dose steroids. So the answer to that is yes, about a third resolves spontaneously, but that's more common for some nerves than the others. So the facial nerve and the optic nerve being one of them.
Dr. Arun, thank you so much for being so generous with your time today and giving great answers to the questions in a really fascinating talk. Thank you very much.
Thank you. Thank you very much, Leonor. Thanks.
Thank you.